Hey everybody, can you hear me? All right, guys, I'm Lori Wise. I'm a nurse practitioner in pediatric endocrinology. And my topic today is just a kind of brief overview of vitamin D, specifically kind of hitting on who to screen and how to treat. We get a lot of kids referred, and I'm sure everybody sees this in their outpatient clinics. I have no disclosures. Um, Vitamin D, the objectives is just to define vitamin D insufficiency and deficiency in different age groups, identify those who would be at risk, and determine who will need replacement and supplementation. And I'll also hit on how much supplement to give or that we would recommend. So what is vitamin D? Basically, fat-soluble steroid-derived vitamin that's responsible for enhancing intestinal absorption of calcium. There's several different forms. Vitamin D2 and comes from plants and supplements, and D3 comes from animal fish-derived. A lot of people ask questions about when we recommend a supplement, if we recommend D2 or D3, we tell them it does not, usually does not matter. If we have a specific recommendation, we would let them know, but generally does not matter. And then the major circulating form of vitamin D is calcidiol or 25-hydroxy. And then calcitriol is the active form with the half-life of 4 hours. And these levels will change with subtle changes in serum calcium to try to keep things regulated. And then the sources of vitamin D in the diet: oil-rich fish, liver, organ meat, egg yolk, eggs, and a lot of our kids are not eating these foods. Sun exposure is huge. And then a lot of our foods in the US are supplemented: milk, infant formula, and breakfast cereals. And then, of course, we can find it in over-the-counter supplements of the D2, D3. This is a chart that goes through the metabolism of vitamin D. And basically, just to kind of hit the highlights, I won't read everything on the screen, but we pick up D3 we get it from the sun, and then it goes through different hydroxylation in the liver, and then the kidneys actually change it into active vitamin D, and PTH secretion is actually in the negative feedback loop there. And then excessive vitamin D will be excreted in the urine. And the skeletal effects of vitamin D, basically it increases calcium absorption from the gut, and this helps maintain the serum calcium levels. This is needed for bone mineralization. And it also acts to increase osteoclast activity to release calcium. And then extraskeletal effects: most cells have vitamin D receptors. Modulation of inflammation, apoptosis of cells has been found in vitro studies. There's some correlation with mood and psychiatric disorders suggested. And then there's a lot of theories about how vitamin D affects different things, including COVID, MS, irritable bowel, inflammatory bowel, and different kinds of cancers. These are often not truly found to be true in studies, but these are questions that we often will get if somebody has come in regarding a low vitamin D level. Vitamin D status in healthy children. It varies highly depending on what guidelines you're reading. Dr. Garganta here in endocrinology, she actually provided the following recommendation from the Vanderbilt Center. This is what she goes off of when she sees a lot of bone patients. So vitamin D deficiency would be less than 20. Insufficiency is 20 to 30. And then anything over 30 would be deemed sufficient. But children who have known genetic or metabolic bone disease, like osteogenesis imperfecta, hypophosphatemia, or XLH, we want to push their vitamin D levels higher than 50. So those would be a special group, and those would definitely be seen here in the endocrine clinic. The daily vitamin D recommendations, again, these differ, but basically all breastfed or partially breastfed infants are needing to have an extra 400 IU. This is usually something that's started at their first outpatient visit, weight check, and then all non-breastfed infants and older children who are not drinking the sufficient quantity of milk or food that would be supplemented also need to have 400 IU daily. And then adolescents, some sources recommend 400 and some recommend 600. This is the amount typically found in an over-the-counter multivitamin. And then some individuals who have darker skin, and I'll cover these on the next few slides, may require higher doses of vitamin D than recommended. We definitely see a large population of obesity in our clinic, and I will say that most of our children who are vitamin D deficient are on at least 1,000 to 2,000 a day to keep their levels in a therapeutic range. And then there's different vitamin D deficient stages. And basically, depending on the deficiency, it kind of depends on how hypocalcemic or what differences we see in their calcium and phosphorus levels. And stage 1 being the mildest, stage 3 being the most significant deficiency, where they are actually have signs of bone changes and demineralization. Clinical signs. So often we don't see clinical signs for mildly deficient states. Dietary calcium absorption from the gut has been shown to decrease significantly or basically be cut in half when there is a vitamin D deficiency. So that does make us worry about long-term bone health. And then we definitely see a reduction of bone mass and increased risk of fractures if they remain significantly low. Rickets, definitely that's something we see here in clinic. You will see different changes in the skull. They will appear to be more macrocephalic, and then the joints and the rib cage will they appear widened. They often have some spinal curvature, and their femurs appear to also have some curvature, and then some just generalized muscle weakness. They also will have poor dentition. And then we also see osteomalacia, which is softening of the bone, and osteopenia, which is a decrease in bone mass. And then there is some thought that there's some abnormal immune function with increased susceptibility to infections and then other long-term latent diseases. And that's what I mentioned in one of the prior slides. So who do we screen? The recommendations are really unclear. Routine screening is not generally recommended in healthy children, but those breastfed infants who are not supplementing or stop supplementing, premature infants, we would recommend screening. Children who have darker skin pigmentation, those with low vitamin D diets, which I think may be a lot of our patients. Children with malabsorption conditions, medical conditions where like they are not weight bearing, CP, things like that, are patients that we see here in clinic for like amenorrhea. We generally screen those. Obesity, we do find that a lot of our kids that are referred for that are vitamin D deficient. And there is some discrepancy over the recommendations of screening versus not screening that population. And then kids who have chronic kidney disease or severe hepatic dysfunction, it's recommended that we screen those. And then the medications listed below, the anticonvulsants and HIV medications, ketoconazole, and steroids, definitely we would recommend screening those kids. We recommend measuring the 25 OHD concentration, 25 hydroxy vitamin D, and that's the best indicator of vitamin D status in stores. And most labs will measure the D2 and D3 and combine them for the total 25 hydroxy. And then the treatment, again, using either D2 or D3. In infants less than 12 months, we recommend 2,000 IU a day for 6 to 12 weeks, followed by the daily recommendation of 400. And then in the breastfeeding mother actually could take a higher dose, 4,000 to 6,000 of vitamin D daily instead of supplementing her infant. And then the older children greater than 1. Again, if they are vitamin D deficient, 2,000 to 4,000 a day for 12 weeks, and then a maintenance dose. And I will say that most of our kids' maintenance doses are about 1,000 to 2,000 a day. I very rarely have anyone that can maintain their vitamin D status on a multivitamin with just 400 IU in it. And then the Strauss dosing is something that I use a lot. If I do have somebody who's deficient, I will actually have them do 50,000 IU weekly for 12 weeks. And then I would recheck them in clinic or have them do 2,000 IU a day until they're seen again in clinic. I find that there are some kids who just are better compliant with that regimen. And then I do definitely see an increased need of vitamin D at higher levels for maintenance with children who are obese. And the children who have rickets, often they'll need the higher doses as listed below. And those patients are generally seen in our clinic, and we would be adjusting their medication based on their response and their absorption. And then generally, we recheck their labs in about 3 months and adjust the dose as needed. And once we get them into a therapeutic range, generally we'll check them again in maybe 6 months to a year, just depending on what we're seeing them for. Do we have any questions? For the patients that you see in your clinic for bone health. And I think Dr. Garganta actually she said that she recommends to keep them over 50. So, and if I have a patient who is not a bone, like a patient that would be we're seeing for rickets or other bone disease, if they're under 20, I'm going to supplement. I'm going to give them higher dosing than if they're between 20 and 30. And honestly, I very rarely screen somebody and have them come over 30 without them being on supplementation. I think we probably all see that as well, that patients will take like a couple months of the high dose vitamin D and then just stop, and they don't realize they need a maintenance dose. Sometimes I'll actually write it on their prescription, their high dose prescription, and then put when done with high dose, please take 2,000 a day. It's hard to say. I think that a lot of people just sort of forget to take it because they see it as a vitamin, and they just kind of forget. And sunscreen while outdoors, does it limit vitamin D absorption? So that's a really good question. So I recommend, because of the sun exposure, that everyone still use the sunscreen. That from what I was reading, it can block some absorption of vitamin D. So, if you're not out in the sun for 10 to 15 minutes a day, then you are probably blocking your vitamin D absorption. To 45 minutes of midday sun to get an adequate vitamin D level, which honestly, with our sunscreen recommendations and just the limit of outside time, I think that's why we see so many deficient children. And yes, Dr. Reynolds is saying that most people do not get enough vitamin D diet-wise either, and so we should just recommend supplementation instead of testing everyone. And I think that is definitely something, sorry, got distracted, something that the primary care doctors are telling people to do. I just am not sure that people are doing it routinely. And,
Hi, Lori. I had a quick question.
uh-huh.
Is there any discussion in the literature about the levels and the different levels as the norms of different levels in different ethnicities?
That African Americans are higher risk of low vitamin D, but lower risk of osteoporosis as adults. So that would also probably speak towards their levels. There might need to be some look at those levels, and there may have been. I just did not see that in my literature search. And then someone asked, For breastfeeding mother, is vitamin D replete? Do we still need to supplement the infant? So it is recommended that either the mother supplement at a higher dose, or that the infant is given at least 400 IU a day.
Sorry, do we know at what level the mom needs to supplement at so that we don't have to give the baby?
Yes. The mother, it's actually recommended that they take a high dose of like 4,000 IU to 6,000 IU a day. Any other questions?
And I know that your focus today was mainly on bone health, but vitamin D was very topical for mental health.
Yes.
Do you have any comments that, if there's a certain level, or is it different for bone health that we need to start worrying about that?
So the bone health needs are going to be higher. From what I could read in the literature about mental health, it's not clear whether or not there's a true tie in, but the general recommendation there was still to get them at 30 if they had any, depression or other mental health concerns.
Thank you.
Mm-hmm.
And Dr. Borowitz asked if you could go back to your slide that has the dosing.
Yeah, we'll go back to that one. Let's see. This one here.
That's good. And would you be able to send us your slides after the presentation?
Oh, sure.
Thank you.
No problem.
And you may have answered this question already, so forgive me if I'm being redundant.
No worries.
Is there a strong genetic component to vitamin D deficiency?
I didn't see that there's a strong genetic component. Honestly, it's just so common now with the lack of, the dietary intake, healthy dietary intake, and also just decreased exposure to the sun for our kids. Melissa did say it's associated with obesity, which can be familial. Given, let's see, is it recommended in COVID? Okay. So I specifically looked into this, and in the beginning, they were, when COVID first hit, they were really looking at vitamin D and seeing if higher doses of that, along with some other vitamins and supplements, would help. But from what I could see most recently, that's not a recommendation. They did not find that it was helpful in the prevention of COVID or the long-term effects from COVID. I do have a few patients who have asked me or have chosen to give higher dose vitamin D because of COVID, and I've checked their levels, and honestly, they were barely over 30 at using 2,000 to 3,000 a day. But I don't think there was any really solid evidence that made that a widespread recommendation.
Sorry, there's a question in the chat about, is weekly dosing better than or worse than daily high dose?
The daily, honestly, it's equal. It's whatever you feel like would be better adhered to by the family. I have a lot of families who struggle with daily dosing, and so I will automatically, generally, if they haven't vitamin D less than 20. My personal preference is to do high dose for 12 weeks followed by maintenance. But in the literature, either one was found to be equally effective. Awesome. All right. Well, thank you guys for joining in.